Hello people, in this video let us look at this topic, Clostridium difficile infection. That is infection caused because of this bacteria called as Clostridium difficile. Clostridium, there are many types of Clostridium bacteria. You have Clostridium perfringens, right? You have Clostridium perfringens which causes gas gangrene. Then you have Clostridium tetani which causes tetanus, right? Now we are talking about Clostridium difficile, and what does this cause? This causes diarrhea. What type of diarrhea? Mostly antibiotic associated diarrhea. That means if a person has taken antibiotics, a few days after that, okay, or even a month after that, he can develop diarrhea. Why? Why? Because the antibiotics that he took has destroyed the normal bacteria in the intestine, that is the large intestine here we are talking about, and this Clostridium, if it was already present or this person got infected, now this Clostridium difficile has started multiplying so much in his intestine that it is releasing toxins, right? There are so many toxins that it is releasing by multiplying. So now this person has what? He has diarrhea. Okay, especially seen in elderly. So that is why we have put this photo. So Clostridium difficile infection we are talking about, CDI. This is antibiotic associated diarrhea. There are instances which tell that it could be fatal if it is not treated early. So are you ready to get started with this topic? Let's start. So Clostridium difficile is a long slender bacteria they are saying. So this is a strict anaerobe. That means it doesn't need oxygen at all, right, to survive. And it is gram positive. So you can see how the dark purple kind. It is sporing bacteria, bulging spores. So you can see spores in this. And it can occasionally be present in your large intestine. In 5% of healthy people, Clostridium difficile is present as normal gut flora. Okay, so it can be normally present, but it will not cause any problem because the other bacteria will be there to control this Clostridium difficile. So what happens when you take some antibiotics? Like we already told you, the bacteria which are there, the good bacteria may get destroyed, right? And then the Clostridium difficile will start taking over, multiplying so much that it will start releasing toxins which will lead to the diarrhea. Okay, so we have finished till here. Now, the incubation period of this Clostridium difficile bacteria is 12 to 72 hours. Okay, so it can multiply, or it is, what do you mean by incubation period? It's more like the number of hours you may need to show the symptoms. Okay, so we'll go with that then. So Clostridium difficile infection, now we are going to look at it in detail. I think you already know, we'll just tell you. Clostridium difficile infection usually follows antimicrobial therapy. So once you are done with antimicrobial therapy, you may develop diarrhea, which is because of Clostridium difficile infection. So what will happen is the antimicrobial therapy altered the composition of the GI, that is the gastrointestinal tract. So the GI flora, the composition gets altered, and because of which the toxigenic Clostridium difficile now has a chance to colonize. So what is happening? This bacteria, because of its colonization, it will start releasing toxins. So it can happen because the patient already has this in his gut flora, or he is exposed to Clostridium difficile spores. How did he get the spores? Either he has come in contact with it from his hands and he has consumed, right? So basically humans are the reservoir. So one person to the other person, by not maintaining hygiene, or maybe he is in a hospital setup, right? So as a nosocomial infection, hospital acquired infection, he may get it, right? Because of obviously no hand hygiene, nurse, doctor, patient attender, etc. opportunistic infection. That means what happens here? It is getting an opportunity to grow because the normal gut flora has been suppressed, right? So it's an opportunistic infection, nosocomial infection. That means because of hospital acquired, right? Then it is exotoxin mediated bacterial disease. Why? Just because the bacteria is multiplying in you, are you getting the diarrhea? No. You're getting the diarrhea because the multiplying bacteria is releasing the toxins, because it's multiplying so much. The toxins it is making toxins, the exotoxins, okay? So, the complications, see let us start here. So, we said antibiotic associated diarrhea, AAD, acute colitis, infectious gastroenteritis because it is caused by bacteria. There is one serious condition that it can cause, pseudomembranous enterocolitis. This could become fatal, okay? Here pseudomembrane is formed, okay, and this is life-threatening. And once what people have seen is when you take clindamycin, the chances of the pseudomembranous enterocolitis is more, okay? So you should understand that pseudomembranous enterocolitis, which is the most scary thing, actually can get caused because of the usage of antibiotic like clindamycin. Clindamycin is there in vaginal creams, etc. In case they want to treat bacterial vaginosis, people would have used clindamycin, and they may land up with this Clostridium difficile infection, okay? So what are the causes of Clostridium difficile? If you know, you can prevent Clostridium difficile infection, right? So avoid antibiotics. So especially in old age, if you're taking antimicrobial therapy, you're more prone to Clostridium difficile infection. So what and all antibiotics should you avoid? So mainly you should avoid third generation cephalosporins, okay? Like ceftriaxone, they are saying. Cefixime. These two I have seen people using. Ceftriaxone, cefixime. Cefoperazone. Okay, all that you avoid, okay? Then avoid co-amoxiclav, fluoroquinolones like ciprofloxacin. Please remember, we already told you that. We didn't tell you. Ciprofloxacin also can cause, okay? Mainly remember this lincomycin and clindamycin, okay? These two you have to very importantly remember, lincomycin and clindamycin. We already told you that clindamycin cream and all they use for bacterial vaginosis, remember? So this clindamycin in any other way also if you are taking, remember it can lead to what? Pseudomembranous enterocolitis, which is a serious part of this Clostridium difficile infection, okay? Now, so avoid antibiotics. Like we told you, broad spectrum antibiotics you should not use. Did we use that word here? Broad spectrum, broad spectrum. Broad, B-R-O-A-D, broad spectrum. So it will kill what? Broad spectrum means what? It will kill more bacteria. So what will happen? You will give Clostridium difficile a chance to multiply and colonize, okay? Now, let's go to the next point, people. How can you, what are the causes if you know you can prevent, correct? So now let us come to hygiene. The next cause, so you know how to prevent. See, it is human, from human to human it is going, right? Human reservoirs. So where is it from one person who has this bacteria in his gut, he'll start passing it on to others from his hand, hygiene, etc. Because this is a bacteria which forms spores. So spores, you know, are very difficult to murder, to kill. To kill spores, bacterial spores is difficult, right? So remember, you should use what? You should use soap, alcohol to wash your hand. That's why you have to scrub before touching patients or after touching them also. You should use a hand rub, right? Then, when you're taking proton pump inhibitors, like you want to treat this peptic ulcer, what do you say? This acid formation in your gastritis, peptic ulcer disease, etc. So you're using proton pump inhibitors, histamine 2 receptor antagonists, etc. When you're using this to reduce the acid, right, production, etc. in the stomach, if you are adding antibiotics along with this, then it is bad. Okay, so remember, you should not do this. And long-term PPI therapy also you should avoid. And then this Helicobacter pylori eradication therapy is there, right, where you give a PPI plus 2 antibiotics. So whenever you're adding antibiotics with PPI, please focus here, people. Whenever you're giving PPIs and with it you're giving antibiotics, you are going to probably freely give the patient what? Clostridium difficile infection, which is not good at all, because it could be a serious condition. Okay, so the causes, what are the causes and how to prevent it, you come to know. Yeah, let's say antibiotics, avoid broad spectrum, clindamycin, lincomycin, what was it? Lincomycin, clindamycin, ciprofloxacin, broad spectrum like amoxiclav, all that we should avoid. Third generation cephalosporins we should avoid. Very good. So this is about the antibiotics. Then what else? Hygiene, because spores are there in this bacteria, and it is nosocomial, so you should be able to prevent by hand rub, alcoholic hand rub, hand sanitizer, soap, etc. before and after touching anybody. Okay, then hygiene over, antibiotic over, hygiene over. Then what was it? Come on, say antibiotic, hygiene, you want to prevent it. Yeah, PPI. So with PPIs, you should not give antibiotics, and long-term PPI use and all you should try to avoid. Okay, so that is it. And then yeah, mainly H. pylori, same, antibiotics avoid with PPI. Same thing, only 3 points are there here. Let's see. Only 3 points are there about prevention. Okay. Now this is a colonoscopic view which shows how the large intestine is because of the Clostridium difficile. So you can look how gross the mucosa looks. So what have they explained it here? So this is pseudomembrane formation they are saying. Numerous adherent pseudomembranes on the mucosa. Okay. Now why does all this happen? Now let us look at this. Active multiplication of the Clostridium difficile will produce two toxins, which is A and B toxin. Focus here, people. So there are two toxins that this bacteria produces, A and B. A is enterotoxin, B is cytotoxin. Come on, focus here now. What are the two things that are happening? See, bacteria is there in some people, but why it's not causing problem? Because it's not multiplying so much. But when it multiplies so much, when it starts multiplying so much, it is producing toxins. And when it is producing toxins, there are two types of toxins, A and B. A is enterotoxin and B is cytotoxin. Enterotoxin means what? It is harmful to the enteritis, means what? To the intestine, I'm thinking. Cytotoxin means it is bad for the cells, I'm thinking. Okay. So now because of these two toxins, what happens? Let's read the statement. The combination of toxin production and the ability to produce environmentally stable stores accounts for the clinical. So basically what's happening, it is able to produce toxin, it is able to make spores, so it cannot be killed easily, so it can reproduce so much, right? So basically that is why it is difficult to control the transmission. That's what they are saying. And then because of the ciprofloxacin, what has happened, there is a hyper virulent strain of Clostridium difficile called as a ribotype 027. This is because of they are blaming ciprofloxacin usage. Okay, so ciprofloxacin is what? Floxacin. Oh, floxacin. Ciprofloxacin comes under what? Yeah, it is coming under quinolone only. It is coming under quinolone only. Ciprofloxacin. It is a first generation fluoroquinolone. Okay, it is active against gram negative. Ciprofloxacin. In typhoid also they use this drug, ciprofloxacin. See, the thing with typhoid is they were trying to treat what? The diarrhea part of it only. So then what will happen? Another type of diarrhea has started off for that guy because of the antibiotic used. Okay. Guys, are you done with this understanding? You have understood, right? Okay. So we told you what and all is happening. Toxins are getting released and what types of toxin, and then hypervirulent strain. So everything we are telling you how powerful it is, this Clostridium difficile. So it can just be diarrhea to life-threatening pseudomembranous colitis. We already told you, right? So it can become something like pseudomembranous colitis. Pseudomembrane. They are not saying it's a real membrane. Okay. And most cases you will see in people above the age of 65. Okay. Fine, people. Next slide, let's go to clinical features. Okay, so we want to look at the clinical features of Clostridium difficile infection. So we already saw that it can become from diarrhea to life-threatening pseudomembranous colitis. Okay, and you will see mostly in 65 years people and above. Okay. Now If you take antibiotic therapy and the diarrhea will start in that week itself or 6 weeks after you took it, it could be CDI. Why? Because see, you have to take antibiotics, then the good bacteria have to die, right? You will take antibiotics, then the good bacteria will get all that good bacteria will get destroyed or something. This Clostridium difficile will get a chance. It will start multiplying. Then it will start producing these toxins which will start hurting you and annoying you and causing all cytotoxin and enterotoxin, etc. So this is when you will start seeing the symptoms. So it can be 1 week of the from the first week to the 6 weeks after taking antibiotic therapy, it can happen. Okay. So incubation period is 12 to 72 hours. So basically this guy either has to get infected with this Clostridium difficile or this Clostridium difficile is already in him. Okay. So that and all you understood. Now, how will it start for him? It will start with lower abdominal pain and diarrhea. And how is the diarrhea? It will become profuse and watery. But actually large intestine doesn't produce that much of watery stools, they are saying. Okay. But not that watery, I'm thinking. Because small intestine, they are saying, is more watery. Let's look at that part of it again, okay, this watery part, whether it's real or not. The presentation may resemble acute ulcerative colitis. So see, it may resemble acute ulcerative colitis because there could be bloody diarrhea, fever, even toxic dilatation, perforation. If it is there, you'll start thinking about ulcerative colitis. But what will happen? Then you will miss this condition which could become very serious, fatal. So you should not, if you are suspecting ulcerative colitis, then you have to rule out this, the Clostridium difficile infection. Then ileus can also be seen in pseudomembranous colitis. Ileus means what? Paralytic ileus. Yeah, some kind of a blockage, intestinal obstruction. Okay, so we want you to remember that it may resemble ulcerative colitis, so but don't miss, because this could be serious condition, CDI. Okay. Now this person will have diarrhea, he'll have fever, he can go into sepsis. Now you can understand why it can become fatal, right? Because it is infectious gastroenteritis. Any infection can lead to sepsis. Yes, you know that. Very good, you people are smart. Now, large bowel, if it is involved, what will happen? There will be small volume diarrhea. How is the diarrhea? Small volume. Blood and mucus could be there. Tenesmus. What do you mean by tenesmus? It's a frequent urge to go to the bathroom, but they won't be able to go. That is tenesmus. Okay. Now there is one score here, people, called as Bristol stool chart. So look at this Bristol stool chart. I am thinking, how will the stool be? Watery? If it is watery, it will look like this, I am thinking. Anyways, that much we are not bothered about. There is some types of stools and Bristol stool chart, etc. We won't go into that. But if it is actually a small intestine cause, no, there'll be lot of diarrhea, watery, they are saying. But in large intestine, they are not using the word watery. That is why I wanted to know if you can write that word watery. Anyways, now coming to the investigations that you will order for the person who has all this. Yes, you want to rule out CDI or you want to catch that it is CDI, right? So what you should do? You should ask them to give their stool. See this stool this is, okay, their poop. So basically you'll have to collect it and then you'll have to find the what? Will you find the bacteria? No, if you find the bacteria, it may just be from a normal healthy person. From healthy person also you can get Clostridium difficile bacteria in his poop, right? So it won't help. So what you should do, you should actually look for the toxin, because toxins will be more, right? If this CD is Clostridium difficile is multiplying a lot. So you will look for what in the poop? You look for the toxins, not for the bacteria. Okay, focus here, people. So the diagnosis you should do of the toxins, A and B toxin, right? So, but still, if you want to grow this, if you want to grow this bacteria and see how it looks, just for microbiology's sake, I'm telling you, it will look something like this. This is the cycloserine cefoxitin fructose agar. Now, this will give yellow colonies because it was producing fructose. Okay. This is all about Clostridium difficile we are talking about. But this you don't need to do, because even a healthy person's poop can have this bacteria. So growing bacteria or proving that there is this bacteria in the poop will not help. You know, earlier I used to think that the symbol actually refers to chocolate. Now I understood that it's poop. Okay. Now we are continuing with investigation. So actually what we want to detect the toxin. Please, you have understood that part, right? Focus, people. Now, what they do is, instead of going and looking for the toxin, in UK what they do is they first screen the stool for something called as GDH. GDH is glutamate dehydrogenase. So this is also an enzyme which is produced by Clostridium difficile. Okay, and if they find this, I think this is easier to detect or something. If this enzyme is there, then they think that yes, there is this bacteria. There's a screening they are doing this. Or if they can detect the nucleic acid of the bacteria itself, then they can think. But I think they'll have to also go with the symptoms of the person, because I may have the bacteria and that bacteria may be present in my poop. You understood, right, people? So anyways, we're still going behind the presence of the bacteria as a screening test. Okay, then what they want to do, they are going to do an ELISA, that is enzyme linked immunosorbent assay, right? Yeah. So basically to find the toxin, they're doing ELISA, tissue culture cytotoxicity assay. Okay, they are doing. So to detect what toxin? We want to detect the toxin. This toxin can be neutralized by Clostridium sordelli antitoxin. So this can be neutralized by this antitoxin. So if this you put and this toxin is neutralized, you know that the toxin is present. Something like that. They're telling you how to investigate, how to detect. Because if you're sitting in a microbiology lab, people, and you want to tell that this patient has Clostridium difficile infection, then what and all you have to do? You have to detect the toxin. Very good. Okay. How will you detect the toxin? ELISA, antitoxin, which will neutralize it. Very good. Now, nucleic acid amplification test, which will amplify what? The genes of the toxin. Right? Nucleic acid means what? Always you're talking about the genes. So you will detect that there is genes which is producing these toxins. The genes also you can detect. Okay. So therefore, the diagnosis is based on the detection of the toxins and not the bacteria. This you understood, people? Very good. Now you just give us a beautiful smile. Smile. So that we can continue. We're looking at what? Clostridium difficile infection. Very good. Now we are done with investigations, I'm thinking. So we told you, right? Tissue culture cytotoxic assay. I think we have already covered this point. No need to cover it again. Now investigations continued. So this is a colonoscopy image. What are they telling you here? You can see that there is pseudomembranes on the mucosa. So this is a serious condition they are saying. So you can do sigmoidoscopy, basically colonoscopy. Put a camera into your rectum, anus, rectum, then colon. So the sigmoid colon is the lower part of your large intestine. So just look at this. They are seeing erythema, white plaques, adherent pseudomembrane. So this may resemble ulcerative colitis. So you have to be careful. You have to detect the toxin. Then sometimes even the rectum is normal, they are saying, and in the proximal colon it can be there. But ulcerative colitis is what? Ulcerative colitis will be continuous and from the rectum, right? So here you can see ulcerative colitis, how it is from the bottom going up. So basically ulcerative colitis and this Crohn's and all are what? They are all inflammatory bowel disease. Very good. They are what? They are inflammatory bowel disease. So it can mimic that. So they are saying, be careful, it will mimic that. You should not miss this, that it is CDI. Okay. So they are talking about X-ray, CT, etc. So you can rule out if there is perforation. Perforation means what? I'm thinking there will be gas in the right side, right, of the X-ray abdomen. Okay, whenever you're in doubt, you can do CT, they are saying. Anyways, those are the investigations. How will you investigate? Microbiology, detect the toxin. Colonoscopy, you can see it may look like ulcerative colitis. So again, if there is ulcerative colitis, etc., if there's perforation and all, you can rule out by taking X-ray, CT. Okay. Now, coming to treatment. Now, we have come off to the treatment, the last part of it, guys. So focus here. Whatever antibiotics you're taking, like lincomycin, clindamycin, all that, you should stop. even if you are taking it in the form of a cream. Okay. Then you should take intravenous fluids. Why? So that the bowel gets rest. Nothing goes into the intestine. So you're taking fluids via the vein to the vein. So you're avoiding the oral and enteric route. Then first line antimicrobial therapy. What are the treatments now? Metronidazole. Please focus here, people. Metronidazole you're giving. Then they're trying vancomycin. They don't want to give vancomycin first itself because there can become resistance. Okay, there can emerge vancomycin resistance, and also vancomycin is slightly expensive. Okay, then there is one more treatment called as fidaxomicin. Okay, this is even more expensive, it seems. Okay, and it has lower relapse rate than vancomycin, but it is much more expensive. Shall we just check what the cost of these could be? This is around 25 rupees, metronidazole. Vancomycin is around 1500, looks like, and fidaxomicin is not even available in the Indian market, looks like. Okay, then you have, so these are the three antimicrobials. See, antimicrobials only caused the whole problem. The treatment also is antimicrobial only, which can kill these bacteria now. Okay, then you have the immunoglobulins, which will give intravenously. Then you have the glucocorticoid steroids, okay, to reduce the inflammation of this bowel, I'm thinking. What do you say, people? So it is used only in severe or refractory cases. Obviously, see, now the bacteria is growing, so you will not think about giving steroid. But in very severe cases, when they want to control the inflammation, they're talking about giving steroids and this intravenous immunoglobulin. Okay, then there is something very strange here called as fecal transplantation. Like your poop can be very useful to the doctor who's doing some research. He's transplanting your poop into this patient. So healthy donor poop they will take and put it in the gut of the patient, so that he will develop a better microbiome profile in his gut. Fecal transplantation. Like I told you, I used to think this is chocolate icon. Okay, then surgical intervention you may need in very severe cases. So this is all the treatment. So summarize the treatment now. Avoid whatever is causing it. Very good. Then give some other antimicrobials like metronidazole, vancomycin and fidaxomicin. Very good. And why you should not give those vancomycin all in the first place? Because it's expensive and because it can develop resistance. Very good. Then you will give intravenous immunoglobulins, glucose corticoids in severe cases. Fecal transplantation could be a solution. Supportive therapy is intravenous fluids and bowel rest, which we forgot to see. Okay. There's another thing called as nitroimidazoles, but we are not telling you much about that, which could be a treatment. Okay, so we have covered Clostridium difficile infection in this video. Please look at it again as a revision. Okay, bye-bye. Remember, people, why this word difficile has come, difficile, because initially when they tried to grow it, right, it was difficult to grow. They used this word difficile. Okay, so from the word difficult only it has come. Okay, so remember, there are many types of Clostridium bacteria. In this video we looked at this one, Clostridium difficile. Okay.